Cool. So we'll start with our presentation. Before that, I'll just introduce the team. Dr. Saurav, Dr. Pratap, Dr. Srinivas Kumar, thanks for having us. Today we're going to do a live demonstration from MGM. Let's introduce the team. I have Dr. Abu to my left, and Dr. Swapna and Dr. Vinod on the anesthetic side, and the entire team of anesthetists, nurses, technicians who've been doing this for the last 7 years. So great team. We'll get on with the presentation. Can you see our slides?
Yes, we can see it.
Okay, so this is a 53-year-old lady, very young lady, history of increasing breathlessness for the last month or two. She's had 2 episodes of syncope, shortness of breath. Next slide. Diagnosed aortic stenosis in the past, was in surveillance, diabetic, hypertensive, hypothyroid, and hysterectomy. Next. Okay, next. So echo showed normal LV function, hypertrophy, moderate to severe hypertrophy. We thought she may have a bicuspid, but we couldn't be sure on echo. Next. No MR. Play. No AR. Next. 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 And the gradients consistent with severe aortic stenosis. Next, CT. This is the CT analysis. You can see here, this showed a small annulus, mean diameter of 21. Next. The sinus of Valsalva was wide, and here we could see a bicuspid type 1 with fusion of the left coronary and the non-coronary leaflets. Clearly 3 sinuses, so not a type 0, type 1 with fusion. Next. This is the angle for implantation and the STJ height, which was favorable. Next. This is the calcium, not a great deal of calcium. Next. Femorals were pristine. Next. So the vital points were, from a TAVR perspective, small annulus, bicuspid valve, LVH, normal coronaries, and good LV function. More importantly, now is the discussion point. She is a perfect surgical candidate. You can't get more low-risk surgical candidate than this. So this patient has been recommended surgery right the first time she had a syncope. She had extensive counseling, and we had extensive heart team discussion. And as always, heart team discussions in this country, we have much more members than in other countries. We had, members of the family from various countries, usually from US and UK. We had urologists, family physicians, everybody. This is the most extensive heart team discussion. So surgery was offered. The patient is hell-bent. She doesn't want surgery. And if we were to do surgery, the plan was to do a root enlargement, because the valve proposed surgically was going to be a 19 or 20 valve, which will give only a 17 or an 18 ID if we don't do a root enlargement. So with all this, with patient preference, which made the decision easy, we have offered TAVR, and that's why here we are on the table ready to do a TAVR. And that's with my presentation. If you have any questions, we can talk about this. Otherwise, we'll do a very quick procedure, and we can talk after.
Gopal, we also have Dr. Sushil joining us on Zoom, and Dr. Dilip from Kolkata on the
Hi,
podium.
Sushil.
Yep. Any questions, Sushil?
Hi, Dr. Dilip. Good to hear from you.
No, I think this is a great discussion, this sort of lifetime management. And we say these patients should get surgery because they're young and low risk, but you also need to plan what that surgery is. And as you said, if you put a 19 valve, the durability of a 19 surgical valve in a younger patient is not 15 years. And you'll see you might get 10 years or 12 or more likely 10, and then you don't have valve-in-valve options. So I think part of these lifetime management conversations is important to involve the patient is what is the goal? If you do surgery, either do a root enlargement or mechanical valve, and ideally a mechanical valve gets the best hemodynamics. If you're not going to do that, as you said, I think TAVR is a very reasonable option here. Do TAVR. When it fails, she will get surgery. As long as the patient is aware of those sort of algorithms, and the hope is that she gets through her life with only one surgery, I think it's also very reasonable as well.
Gopal, my question to you is more.
That's useful.
Yeah, very good point, Sushil. My,
Yeah.
my question, I think these people with aortic stenosis and LVH are more likely to have amyloid as well. So are you testing for amyloid, and if so, how frequently are you testing in aortic stenosis patients?
So what we do is I use a very simple test. I just look at the ECG. If you have voltage criteria for hypertrophy, it's unlikely to be infiltration with a thick LV. So if you have a thick LV with no voltage criteria for hypertrophy, one has to think about infiltration. That will include amyloid or whatever infiltration you may want to consider. But if patients have a thick LV but no voltage criteria for LVH, I would do an MRI before. But this patient had clearly LVH, long-standing hypertensive, and voltage criteria for hypertrophy. I don't hunt for an amyloid unless other clinical reasons persist.
I think we'll proceed with the case, Dr. Gopal. Good discussion. We'll go ahead with the steps. Yeah, we are running.
All right, great. So let's start. The case, we've already done some basic preparations. The choice of valve, in this case, I have decided for a balloon expandable valve. And I'm choosing a Sapien S3 valve. And I feel balloon expandable is best for this patient and for most bicuspid. That's my preference. I'm happy to discuss on that later. And the reason for that is I like a very circular orifice. I think increasingly we're going into TAVR in TAVR. And therefore, if one wants to minimize target valve revalving, I would call it TVRs, then achieving a perfect circular structure is very important, I think. And for that, you need good radial strength, especially with bicuspids. So personally, I always go with a balloon expandable for anywhere where I want radial strength and I really feel that I can get a better circular structure and absolutely no gradients from a TAVR procedure. So that's why I'm choosing a balloon expandable. So you can see the fluoro, standard vascular access, ultrasound guided. We have 14 French from the right. We have 5 French from the left artery and an 8 French venous line. Because we don't put a central line, we slave it to the anesthetist, and the 8 French venous line for a temporary wire. So that a temporary wire has been positioned. Next, E-sheath in. Next. And then we cross the valve, standard, next, 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 next. Great. So we got a Safari in and show us the implant aortogram, please. So we did some minor adjustments. You can see 3 cusps. So we're happy with this view and ready to proceed. I can take some questions while I get the valve into position. Yep. Got the wire, Babu?
So the annular area you got is only 350, or how much did you get? Annular area?
360.
360. Yeah. I mean, on the aortogram, it looks much bigger. 360.
Mm-hmm. It's a magged, so we magged it quite a bit.
We are now evaluating. Dr. Dilip had a question: why balloon expandable valve? In a small annuli, we are looking at a trial called SMART trial between balloon expandable. Yeah.
Come, Caudle.
So Gopal, the question is why balloon expandable with the good?
Okay.
Actually, Gopal, the question is actually with a hypertrophied muscle with a small annulus, why do you go for a balloon expandable rather than a self-expandable?
Because with a bicuspid, I want good radial strength, and I want to be able to get a circular valve after the implant. This is very important for me. And I don't want to do pre-dilatations and post-dilatations if at all I can avoid. I want to minimize instrumentation to the aortic valve. And for all these reasons, balloon expandable have ticked the box for me for all these years. And that's the reason I'm choosing a balloon expandable valve. Okay, we've crossed the valve, I think. And let's just do one final check. Okay, that's great.
Could be better with this.
Long term, there is a difference created.
Absolutely. So that's the other reason I forgot to mention. I think I don't want to jail the coronaries. I want a wide area there. And for all these reasons, for any young patient, for whatever reason they end up requiring a TAVR, my preference has been a balloon expandable. I know you can do, we do a lot of self-expanding, also great valves. In fact, the youngest patient we did years back was a self-expanding evolutar, and today he's the longest living evolutar in India, 7 years. But then now we have balloon expandable. We use this increasingly because if we can avoid jailing the coronaries, why not? Inject.
Gopal, the earlier point that you had made about preserving future TAV and TAV options, I think that also makes balloon expandable a slightly better choice here. Although I think in 10 years or 12 years from now, when this valve fails, should still be, hopefully, we still be a good surgical candidate.
Naga. Yeah, so I have counseled the patient for a TAVR in TAVR and a TAVR in SAVR. But I guess I'm not sure she'll take a SAVR, having not agreed for a SAVR on the first time. But I think to shut me off, she said yes.
Well, this valve will never fail.
It's very optimistic. We'll know. So you can see here, even though we positioned the valve right, loaded it right, there's a little bit of offset between the markers. I'm bearing that in mind. I want to have a high implant as much as possible. So we'll see. All right, guys. Ready for injection, guys? Give me an injection. Inject, ready? Okay, Abu, ready?
Little deep, I think, right? Yeah.
So, yeah, I'm just going to come back a bit, but mind you, Ramesh, I'm also bearing in mind I am higher than where I think I am.
Yeah.
Because
Your
the
balloon
valve
is
is
the
slightly
deeper.
offset. I've borne that in mind. Correct. So I've just, but I'm going to do slight movements. But more than the balloon, I look at the translucent area. I think we all do that now. So we're happy we're where we want it to be. Inject, guys. Inject. All right, great. Terrific. Hold on. Okay, ready for pacing? Yes, sir. Music off. Pacing on 200. Yes, sir. Small injection. Okay, start going, Abu. Start going. Going. All the way up. Okay, 1, 2, 3, down. Okay. Okay, good. Pacing off. Okay, great. Coming back. Okay, get a wire. Ready? Small injection, just check. Check, guys. Okay, good, I'm happy. Let's do a bailout, 1 second. Pressure's coming back. Okay, 1 ml. All right, pacing on. Yep. Pacing on. All the way up, Abu. Down. Okay. Coming off. Stop pacing. Hold the sheet for me.
Pressure recovery is a little slow, you know.
Yeah, it's slow. Yeah, I can give some pressures.
Maybe give some AP or. Yeah, I would normally just inject AP through the through the balloon sheath.
Yeah. No, the anesthetist is just doing that, so we got things under control. I'm happy. So map is 56, so we can take a time. She's fine. So this patient, I'm very worried. I was very worried about the conduction abnormality that one could get because she's had 2 syncope. Anybody has syncope, I'm very worried that it may just be a conduction abnormality, because I still struggle to believe that it's all due to aortic stenosis. However, she had absolutely no conduction abnormality on baseline ECG, and her membranous septum was only 3 millimeters. So I was very, very cautious to make sure we have a very high implant and not leave her with a transplant with a pacemaker, because young TAVRs with pacemaker, not a good idea. Pigtail, please. So the aim was to get zone 0 or +1, that's it, not more. So I aimed for a very high implant. So let's see where we get to. The pressures have come back. The diastolic is 74. So let's put a pigtail, guys. Ready for 2 pressure lines. So the intention was to get a high implant, if possible, zone 0, and that's to avoid a pacemaker. So let's see. So we have intrinsic rhythm. The PR interval looks normal. There is no conduction abnormality that I could see. Hold on a second. Okay, great. All right, get the valve parallax, guys. Go on. Okay, music on. Okay, ready for an injection? Parallax, can you a little bit of parallax, please, there? No, the other way. Stop it. No, opposite. Bit more. Stop there. All right, ready? 20 at 15. Pressures down, please. 20 at 15, please. Okay, no pacing on. Okay. Ready? Inject, guys. Okay, good. So let's take the pacemaker off. We don't need a pacemaker. All wires are ready to close, guys. Get a pressure, final pressure, and then we're done.
That's a really nice depth.
Right, we're done. We're just going to do a pressure evaluation, and then we'll be done. We'll just show you pressures, and then we'll be done. Any questions, any comments, anything to discuss? We're just going to close off unless you want to see closure, but I will leave that to the panel to decide.
Yeah, so did you see AR? What was the reason for post-dilatation?
Because I could see there was about 1 millimeter, I saw just with the injection with the delivery system there, and I thought there was a little bit of room. I put a 23 nominal, 17, and as a policy, I always have a bailout syringe next to me with 3-4 ml. I make a decision based on the fluoro screen that I see. If there's room, and if I can still pull the valve up from wherever it is, I would do that. That's providing this room, and of course, I have all the CT information. I know if the risk of rupture is low, I would do that. So it's a routine thing that we do just to make sure we get a perfect precision.
Yeah, Gopal, I was telling that you told I will not.
So we're just getting pressures there. Yes, Dr.
I will not
Pratap.
do a pre or post dilatation in this case. That is what your first comment. And finally, you did a post dilatation, so immediately you saw mild regurg. So you thought you'll just do a dilatation immediately and created the excellent result at the end.
Yeah. So of course, the intention is not to post dilate, but when there is a necessity, I do it. So.
Yeah, absolutely.
Great demonstration.
Great.
Sushil is commenting.
So at the end of the day, what we want, especially with low risks, is we want absolutely a good circular valve. We want no gradients. We want no MR and no pacemaker and no complication. I think this is very important for a low risk TAVR, and that's why all these maneuvers and the thought process.
Yeah, absolutely.
Just flush the lines, please.
Yeah, they're on vasopressors. I think it was given. Probably you're coming down on the pressors now, right, Gopal? Any support?
Yeah, we're coming down on the pressures. We just saw the gradient. No support, actually.
No support.
So we're just coming down to support. There's no gradients. You can see here, 170. Let's flush it, please. Flush and then come back. Flush the line, please, for me.
Yeah,
flushing the line?
I think the one
Your
comment
side?
I'll make is during
Your side?
the deployment, the valve really sort of moved up at the tail end, and whether that's the septal bulge, or other things, it can happen
No,
with the balloon
because
expandable. Came up to a
just
perfect
show the
position.
valve deployment, please, because
just-
I moved it slightly up.
Yeah, I
show
also
the deployment.
felt the same way, that it definitely moved up a little bit.
So as we were going up, you can see here, as we were positioning it, the valve and the balloon, there was an offset of 1.5 millimeters. I think you all agree on that. So therefore, my positioning was based on the translucent area. And the plan was during implantation, if there was any concern, I'd pull it back a bit. You can see my tension there on the guiding system, on the delivery system. So the idea was slightly to pull back and push on the wire, so that we get as high implant as possible, because membranous septum was only 3.5. So I was really worried this patient might end up in a pacemaker, so hence the reason for that.
Yeah, you did it very, very good. But this is sometimes I'm very concerned that it can embolize at that time, So, but perfect result at the end. Thank you. Thank you, Gopal.
So the last
Congratulations,
imaging,
Gopal,
please.
for an excellent demonstration. In young patient, also surgically refused, you said, and you did this
Next.
and showed it well. In US, suppose on patient of 53 years doesn't want surgery, would you advise TAVR?
Yeah, I would certainly offer it to them if they said no way surgery. So it's not a hard stop, but obviously this is a patient we would, just as you did, try to convince towards surgery as much as possible. I think that's a great positioning. I mean, the only thing that crosses my mind is, and you have to balance the risk of a pacemaker, of course, but sometimes if the risk of pacer is not that high based on the membranous septal length, then I actually favor slightly lower implants, because I think it preserves the TAVR and TAVR options a little better downstream.
So in the US, patient doesn't want surgery is not a reason to do TAVR. The surgeon has to document. Previously, it was 2 surgeons have to document. Now, at least for CMS guidelines, everybody, all the insurance companies require at least 1 surgeon to write on a paper why he is not going to operate.
And in US, other system is both surgeon and interventional cardiologist has to be present in cath lab to get your reimbursements, I was told.
Yes.
So anyway, I think here Gopal showed an excellent case. Congratulations. Any final words? People here, hall is full, they are all applauding
Short,
you with claps.
Elio?
Yeah, I think we are about to leave you. Any final words? Thank you again for the great demonstration. Okay? Great. Thank you.
Thank you all. Thanks
Yeah,
for having
thank
us.
you. And